Hi, everyone, and welcome to our CPE Speaker Series for May. We have the pleasure of having Megan join us from Tomorrowland, I'll call it, New Zealand. So we're really thrilled that she's joining us here today, especially at a very early time of day from where she'll be presenting at. You probably know my face as the administrator for the Center of Practice Excellence. In conjunction with Zub in Austin, we host these regular monthly events highlighting innovations in research, education, pharmacy practice, and innovation, and are really thrilled to round out sort of our spring sessions for the CPE Speaker Series with this presentation today. I'll just hand it over to Emily briefly, my co-facilitator for today, to introduce herself as well.
So welcome, everyone. It's always a pleasure for me to be here with Annalise. So my name is Emily Musing. For those of you who I've not had the pleasure of meeting, I'm the inaugural leader in residence for the Faculty of Pharmacy this year. And as such, I have the pleasure of working with all the faculty to look at ways to embed leadership exposures and opportunities for our students, and of course, for our alumni as well. And this is one of the fun things I get to do, is to participate in these types of really great sessions with Annalise and with Zubin. So welcome.
Yeah, thank you so much, Emily. We were very lucky to have you with us. You bring such a wealth of knowledge and experience. I'd just like to start today's session with an acknowledgement of the land that I'm on today here at the University of Toronto. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we're very grateful to have the opportunity to work and learn on this land. For my own path to truth and reconciliation, I personally have been reflecting on the benefits I've had as a settler from living on this land here in Treaty 13 in Toronto, but also throughout my education and training on the land in Ottawa, British Columbia, and in other parts of the world as well. I'm really grateful to work towards a deeper understanding of the history that's brought myself and all of us here today to reside on this land or whatever land you might be on today, and to work towards creating environments of mutual respect and learning. So with that being said, our event today is looking at the role of pharmacists as decision makers in therapeutic contexts within the profession of pharmacy, with patients and with other healthcare providers. And as I mentioned, today we're going way across the globe to learn lessons learned from the New Zealand context. We're very fortunate to have Megan as our presenter for today. And we'll probably be wrapping up with about 5 or 10 minutes before the hour. But Megan has kindly let us know that question and answer throughout our conversation today is much appreciated. Few housekeeping items. We'll just ask that you keep yourself muted and please put any questions and comments in the chat, and we'll get to those throughout the presentation. And I'll just pass it back to Emily now to introduce Megan, and then we'll get going.
So it's my real pleasure to introduce our speaker today. So we're in for a treat, Dr. Megan Anakin. Megan, I feel like I should say Skywalker after that for all those Star Wars fans, is an academic senior lecturer and an education advisor in the education unit for the Dunedin School of Medicine, University of Otago, Dunedin, New Zealand. So she provides support and advice regarding teaching, learning, assessment, evaluation, and education research, primarily to people who teach medical students in the three final years of the Bachelor of Medicine and Bachelor of Surgery program, but also to clinical educators across the Division of Health Sciences. Megan researches how patient care decision-making skills are learned and taught in a range of contexts, including workplaces, simulation, and interprofessional educational initiatives, and how this knowledge can be used to inform curriculum and faculty development in the health professions education. She's passionate about building education research capability in teachers and students, and we're really happy to have her here with us today. So Megan, it's all yours.
Thank you, Emily. Thank you, Annalise. I hope I can live up to that big biography. I'm getting tired just hearing about it. Here we go. I'm going to just fire up a PowerPoint here to help illustrate a story I want to tell you today. So very quickly, I will get this PowerPoint going correctly. always fun dealing with technology, and it's difficult to see you, so I will do my best to maintain engagement with you. When I was invited to do this talk, I was trying to think what would be really engaging. How can I demonstrate some rigor for you and also make things accessible? So to do that, I think to contextualize where I'm from, you might detect a Canadian accent. So my heritage is as a Canadian. I was born in Montreal, so sorry, Torontonians. There's a bit of rivalry that will happen today. And I can see why. I don't want to make a gendered comment, but I might. I'm wondering where all the boys are. They're probably lining up to go to the hockey game. If I've offended anyone, please excuse me. So I would like to acknowledge my history as a Canadian, and I feel really privileged to represent Canada and be welcomed here in Toronto. I'd also like to acknowledge Maori as Tangata Whenua and the Treaty o Waitangi as partners in my current homeland, Aotearoa, New Zealand. And for those of you who might not know that much about New Zealand, as you can see, has two main islands and a third wonderful smaller island at the bottom called Stewart Island. I reside on the South Island here, the main South Island. And as you can see, Dunedin is in the south of the South Island, and we are definitely in the South Pacific. Our country has almost got a compression of Canada. I feel very much at home here. We've got big mountains, we've got plains, and we've got coasts. However, we don't have the distance to travel. It's a couple hours to get across from the east to the west coast here. That being said, we only have 5 million people in our country, and only 1 million live on the South Island. My hometown, I call it more of a town than a city. We have about 100,000 people here in Dunedin, and we are dominated by the University of Otago. And you can see the Tudor style architecture. It's New Zealand's oldest university. It was established over 150 years ago. I'm going to cast my gaze to a less attractive building here right now, which is the home of our School of Pharmacy. I wish I could say we had a grand building, but the School of Pharmacy occupies the 4 top floors of this wonderful building. And 6 years ago, I had the privilege of working at the School of Pharmacy for a year and establishing some connections with people that are enduring and a research platform that is ongoing. And so today, I want to take you on a bit of a journey through some of the research accomplishments and questions I've been asking and the answers we've been trying to construct together, and then end up at this wonderful place. This idea that the roles that pharmacists have been adopting in New Zealand are as networkers and advocates. And here's just a little sample of some of the things that some of our participants have said in a study looking at advanced practitioners. I'm not going to read it to you because I know you can all read in its big font. I don't know if these words resonate with you, those of you who have been in practice, but I think this definitely helps give you a sense of where we're going to end up in the next 40 minutes or so, is really understanding why pharmacists in New Zealand are feeling the way they are about themselves as pharmacists. I know the profession globally is going through quite profound changes. I know in New Zealand, there's a big disruption going on, and we'll get to that a little bit later. So let's start with some background. And since it is May the 4th in Canada, I will try not to make too many Star Wars references. My last name should be sufficient for those of you who are fans, but I do want to provide some background context for the study that's the main focus of this presentation. So as I said, 6 years ago, I had the honor and privilege of joining the School of Pharmacy and learning about the world of pharmacy education. My background is as an educator. I've spent several decades in classrooms in Canada, the UK, and New Zealand before moving into tertiary education. And I didn't realize that I would fall in love with pharmacy education and medical education and health professions education. Learners are the same, whether they're children or adults or doctors and nurses and pharmacists. There's some really important parallels. I did work in the education department at our university, and the parallels between professional programs, I think I draw strength from. We all take the lead from practice. So that's where we're going to go with this presentation today. What knowledge, skills, and attitudes do students need for practice? And a big question I'm really interested in is how can we minimize the challenges graduates face when establishing their practice? What factors are at play? And how can we design fit-for-purpose learning activities that enable them to go out into the workforce confidently and not abandon their future profession after investing so much time here? You'll notice I won't use the word optimal design or best practice, because we're in a socially constructed realm here. And I think this will be a theme in the quagmire that I have found myself from time to time in the studies I've been doing. So I'll take you there shortly. So before I move on, are you facing a similar challenge to what I've presented in those quotes from our participants? Given this challenge of fitting into practice as a new pharmacist, how might you approach this education practice transition problem? If you have any thoughts, please drop them into the chat. You don't have to answer this question, but I think thinking about it for a moment will help you set up to engage with the ideas I'm going to present. So I'm just going to be quiet while you reflect, or Annalise or Emily, if there are any points that you think should be brought up at this point, I'll be quiet for a moment while you speak.
So I just want to say, I think that, what I heard so far really resonated. And it's certainly similar to what I hear from students that I speak to in various courses, people and pharmacists, frankly, that are out there in practice, because I think that the role of pharmacists is constantly changing. And as individuals, we're constantly trying to search out how to meet the needs of our patients and how to best fulfill those roles. So I think we're really interested in your findings and your research.
Thank you very much. Annalise, is there anything you want to add?
I've just encouraged people just quickly to use the raise hand function, because I think we have a small enough group that if people want to type in the chat box, that's great. If they want to raise their hand and sort of weigh in, I think we can welcome that. Katrina had put a comment into the chat, and her comment is she thinks the lack of confidence may be decreasing with the advent of electronic health records and having an incomplete picture of a patient's health within community pharmacy as a result of sort of that fragmented landscape we often see in Ontario, especially.
Thank you very much. And that desire to have sufficient information, I think, is a theme you're going to see in many of the findings that we have here. Anything else that anyone would like to say before we move on?
I'm sorry, Annalise, I don't seem to have the raise hand function.
Oh.
I don't know why. Anyway, I don't, so I'm just going to butt in.
Right.
So I'm Dan Wright from the University of Otago as well. So I'm a pharmacy educator. I haven't practiced for quite some time, so don't have a practice perspective, but I have an educator's perspective. And I think the biggest challenge we have, and I don't want to preempt anything Megan's going to talk about in any way, but the biggest challenge we have is that there's a disconnect between what we're teaching our students and what they experience out in practice. So the profession is on the whole doing one thing, and we're teaching them another thing. So we're teaching them very much to be clinical practitioners, to be in the setting them up so that they're in these face-to-face clinical roles with patients, and then they go out, and a lot of their experiences are quite different. That's a real problem we've got at the moment. And students lose faith. They'll go, well, there's an ivory tower education thing going on here, but it's not really what happens. Now, I think that is changing too, as Katrina has mentioned. Things are changing as we get better access to patient records. That's a good point, and various things, but it's slow to change. So just throwing that out there as a thought, that as an educator, that's probably our biggest issue, one of our biggest issues.
Dan, I think that's a really good point. I just wanted to point out, if there's anyone else that can't find that raise hand, you might see looks like a smiley face with a plus at the bottom that says reaction. So if you click on that might open it up.
Got it.
And I love what you just said, Dan. I think that one of the things that I found in trying to embed what we're calling leadership, skills for pharmacists, but I think really applies not just to do with leadership, but to do with pharmacy in general, is the need to be able to be flexible and adaptive to what is required, to take the many great things that you are learning in school and to figure out how to apply that to changing environments that you may find yourself in.
Yeah, good point. Thank you.
Yeah, and maybe one more thought on top of that is, I think, just the importance of interprofessional education and actually being able to interact with, like Megan, your quote sort of said, doctors and nurses, are maybe a bit more okay with that uncertainty, but I think role modeling and being able to see yourself of having that same confidence or how you fit into that picture and taking on those roles.
I also see a hand. Jasmine has her hand up.
Yeah, to add to that, I was going to say that this really highlights the role of networking, communication, collaboration, and advocacy within pharmacy, because in order to translate knowledge to practice, I think those are crucial elements.
Thank you all so much. I feel like we're kind of unified in understanding the problem that I'm trying to tackle. And, I think I've said very clearly, I am not a pharmacist. I come in with an education person's gaze. So I have to seek colleagues to do this research with me, because I don't understand the intricacies of practice. Despite being married to a pharmacist for over 30 years, I still really do not know what you wonderful people do. And it's probably good, because it allows me to ask those questions. Why are you doing this? Can you tell me more? So that is what the strength I bring to this, but I do not do this research alone. So I just want to take you on a little bit of a journey about how we got to this place. And it started a little while ago with the first challenge, which was, how do we establish an explicit theoretical perspective for looking at this? So a group of us at the School of Pharmacy in Dunedin started thinking, well, what could be a starting place? I'm not saying this is the best or the only. And we looked at bioethical principles, because we thought inside of people, these are very important drivers. And two of them are the idea of beneficence, to do good, and non-maleficence, to do no harm. And we were thinking, how do pharmacists balance these two pressures? And as we thought about this, and this was very much a thought exercise, this piece of research, is we were able to sort of identify 3 categories of services that pharmacists provide in New Zealand. And this may be true in Ontario or in Canada. This is 6 years ago too, but I know practice is always shifting and changing. But we thought about that non-maleficence was that checking, which we know we could probably get the robots to do now. Secondary beneficence, which you heard in those quotes, which is making recommendations and supporting other health professionals. And then the idea of primary beneficence, where pharmacists actually step up to the plate and provide that care confidently. And I know in New Zealand, we do have prescribing programs, and we're trying to develop that base. So we were trying to find a way to start interrogating this thing. The second piece of the puzzle was just identifying the terminology. So Dan has been really wonderful in leading the charge. Do we call it clinical reasoning? Is it clinical decision-making? When we were presenting this research, we were always challenged by the words we were using, because people have different words they use and different meanings assigned to what these words are. We've been trying for years to actually do a review of the terminology and come to consensus. And if any of you are interested, we're still working in that area. What we did do was just go to a generic model that's out in the literature, in the psychology literature, that was very simple in the beginning. And it just had 4 steps. You gather information, you think about it, you weigh it up, and then you do something. And we thought this really simplified model might be a starting point to help us look at data. So we brought this out and we started with students, because being a teacher, I like to start with students. So we had students be involved in the research. Not only did students be interviewed, they were interviewing one another. And they were using this model to make sense of their learning experiences. And lo and behold, when we used our 4-step model as our analytical lens, we found that students were identifying medicines related problems, usually via differential diagnosis. A second step was exploring treatment options. They were aware of that. They knew about weighing up the options. And the 4th step they articulated was making a recommendation. Very interestingly, attitudes were about confidence, open-mindedness, and bias awareness. So these were the things that students were seeing in our program before the educators were explicitly teaching any model to them. And that's been the way education's been in New Zealand. Dan and his colleagues introduced more explicitly this 4-step model into the teaching. And the next year, we asked the students a similar study. They interviewed one another and they were able to compare when this model was introduced to beforehand. And very interestingly, a challenge emerged for us, another challenge. What happens when you involve students as researchers? It is about building educational research capabilities, but it really limited what we could see in the data because of their ability to analyze the data from this philosophical perspective. You know, 4th year pharmacy students are still coming to grips with the knowledge and skills of pharmacy practice. And so their ability to understand pharmacy practice really limited what we could do and say. So this really excited us to probe further. And we thought, well, let's ask some people who are out in practice what's going on. And so we decided to do a pre-post kind of study design with some practicing pharmacists who had come back to the school of pharmacy for some graduate coursework. However, the challenge with pre-post design, those of you who do education research know that, guess what? If somebody doesn't know something at the beginning and you teach them something, they will probably demonstrate it to you later. And so being able to control is really challenging. So guess what? They learn what we taught them. And then we're sort of left with the, so what? Of course, they're going to learn what we teach them. I guess the good thing is models are teachable. I guess that's the take-home lesson we got. They're willing to take this on board, and when we teach it to them, they can demonstrate it. But will they use it in practice? And is this really the best model for them to be using? So this led us to the next idea, which was once again involving the students, but looking at data that came from our advanced practice pharmacists. This was really, really exciting because they were actually starting to pick up on the activities that pharmacists were doing and really helping us to understand how our perspective would inform the research. We finally got a publication, yay, from all of our efforts using data from these practitioners, but we had to simplify the problem. We only looked at 10 of 17 interviews that I conducted with these advanced pharmacists. Why did we do that? Basically because things didn't fit. And sometimes we have to make decisions to be able to communicate ideas and bring things forward. So what I want to do is just take a minute now. I'm going to stop sharing. I can do that. And I just want to share some of our findings with you so you can get a sense of how challenging this is and why we've now taken a different tack. So pardon me while I just get some of my findings up for you. And I'm just going to change my background so that you can see how what I'm saying has spurred us forward. So if I take our little model, which we don't use this anymore, and I'll present our revised model, but since we're sort of doing a little bit of a history lesson, I think it's important that we visit this place. So for the first step of the model, information gathering, our practicing pharmacists talked about using documented information about a patient. Gathering that information was really important. One of them said, you need to have a lot of information. So I guess before I make a decision, I make sure I look at everything thoroughly. You have to go back and look why they were started on something and see how long they're supposed to be on something. So this desire to have all the information. They also talked about using communication skills to elicit information from a patient. And I think that's a very important part of this decision-making model that is missing and why we've had to revise it, because there's consultation with the patient. And the participant said the patient is an expert on what's happening to the patient. So there's this bi-directional communication that's going on that we weren't really able to put in the model that we were teaching students. Recognizing past experiences with treating other patients and apply these to current patients. So one participant said, you build your own experience and you start to think back to other patients where you might have gotten into a similar situation. And our students don't have this to rely on yet. So there's another piece missing. And then finally, of course, they refer to existing protocols and guidelines while being aware of their limitations. That's quite tricky to get students to understand the limitations when they're just grappling with that. Now, the other three pieces of this model were almost invisible in our data. What they could say about the reasoning step was, well, you kind of synthesize that information a little bit and decide that it needs what needs to be done. So there weren't words for these invisible tacit thinking processes. And even at the judgment stage, they would say, I was worried about his blood count, having acknowledged that we've put the respiratory bit aside. So in their conversations, you could hear them sort of weighing things up, but not in a detailed way that we could actually translate to a lesson for students. Again, even our practicing pharmacists were very uncomfortable with uncertainty, but there were facets that they were learning how to be accepted. And there's some great literature right now about comfort with uncertainty that I'm now pursuing, but I'll watch with anybody who's interested. And I think I've already shared the quote with you. I don't like making recommendations unless I know they're right. I struggled with that a little bit in situations where there's no right answer. And quite often there is never a right answer. And how do you teach students to navigate that space? And then finally, that fourth step which is enacting the decision. Our advanced practitioners wanted to involve other healthcare professionals and the patient in the decision. So we know that this is a real struggle to actually make the decision. It's easier to sort of hand it off to a colleague. I guess the best way one participant described it was, the more you understand about patient engagement, it doesn't really matter what you prescribe. If you haven't got the patient on board, it won't happen. So all of these findings, while really wonderful, threw up a lot of questions for us. And I want to take you back to that place with us. I don't know where my PowerPoint has gone. Considering your experience and perspectives, how does this approach that we've taken and these findings and how we're addressing it impact with illuminating this transition? What might you learn from our efforts so far before I take you into how we flip the problem around? I'll just pause for a minute for you to think and consider and see if anyone wants to add anything at this point. It's important to let people have think time and wait time.
Thanks, Megan. I think I'm happy to maybe start us off. I think one of the things that really struck me sort of from where you started to now is using that ethical lens to sort of be a real tool to look at decision making, because I think a lot of clinical scenarios and clinical education is a lot more about weighing these things of harm versus good and facilitating these conversation pieces, rather than just saying, I can't do anything until I have all the information, or, I can't do anything until I validate that with someone else. So I think it logically makes a lot of sense to me. And I think that that's a really great direction of where things could go, at looking more at those interpersonal factors, how to teach comfort with uncertainty. I think that's a great one. I'd like to hear more about during this conversation. But I really, really appreciate that lens that you're bringing to the work.
Thank you very much. Anyone else with a comment they'd like to say? You can put up your hand or just unmute yourself if you would prefer to speak. I can't see the chat, but perhaps there's something, Emily, you can
Yeah,
share.
we're keeping an eye on the chat as well. I was just going to say that the one point that you made that really resonated with me is the importance of the role of the patient in that decision-making process, because you can't make the decision for the patients in a very paternalistic mode and still expect good consequences. Because I think, our patients are becoming much more self-aware of both themselves and their health state, as well as they have much more accessibility to information, whether it is evidence-based information or it is, other information that's available on the internet. And I think that we really do them a disservice when we try to engage other members of the healthcare team in decision-making without fully acknowledging the role of the patient. And I see Dan has his hand up as well. Go ahead.
I guess I was just going to add to that, this whole idea of risk benefit and so on is key to all of this benevolence, non-maleficent versus beneficent and so on. And when you're looking at coming to decisions about optimal therapy, for example, the perspective that we've got as well is that there can be multiple right answers. So getting down to a single right answer is actually probably somewhat destructive in terms of decision making. And I wonder if that's something that pharmacists traditionally, and as myself as one as well, when I practiced, have stumbled with. They want that nice, clean right answer when there is actually not only is there uncertainty and no right answer, there may be multiple reasonable answers too. So it adds more complexity to the decision making. That's different in diagnosis, or at least it's certainly conceived that way, and to be different in diagnosis, where you've got all of this information about what's going on with the patient's symptoms and such, and you trim those down to a single right answer. And if we apply that to pharmacy practice and to treatment and therapy and optimized therapy, I think actually ends up making us stumble. Because there can be multiple right answers, as in addition to the already inherent uncertainty around things. So deciding what's the right or the optimal therapy for this patient sitting in front of me is the challenge that I think is a difficult one to navigate as an educator.
Thanks, Dan. And that brings me back to the point that I made at the beginning, is really thinking about the language we're using. I'm really advocating fit for purpose, because it allows you to contextualize things to the patient's lived experience in their life. If we're always thinking of optimal or best practice, that reinforces that idea of one right answer, or sometimes one size fits all. And that can be highly problematic. So here we go. I'll try and share my screen to take you on the journey of where we are now, and get us to the place of, I just have to toggle again. Sorry for the delay. There we go. So we've had a chance to think about this. So of course I go back to the drawing board, because Megan is always inquisitive. And I thought, are we at an impasse here? We've been trying to study decision-making or clinical reasoning, or whatever this thing is we're calling this transition into becoming a pharmacist, as this invisible tacit mental process. We've really jumped on the cognitive science bandwagon, right? And it's kind of a safe, comfortable place for my pharmacy colleagues who've been trained as scientists to go to. And my first degree was science. However, my second degree was fine arts, and I've since gone into this wonderful other realm that I've been studying for many years. So I'm thinking, but what if, what might be visible if we view this problem from the lived experiences of pharmacists, of what they can say and tell us about, rather than trying to use the words as proxies for something that we cannot see. So what if we adopt a really socially situated perspective? We view pharmacy practice as being shaped by the culture. And by culture, I don't just mean a national culture, but the profession's culture, the workplace culture, you know, the profession's culture. And we also recognize that there are roots that go very deep historically. And we've spent some time thinking about the history of pharmacy and where does it come from. So this became now not an impasse, but an opportunity to revisit these interviews that I collected in 2018. And for me, it felt like a door opening onto this amazing new landscape. And were we willing to step through? So the stepping through allowed us to reframe our question, to think, what are the characteristics of advanced pharmacy practice in New Zealand? So in this case, back in 2018, we were able to contact just about everyone that the School of Pharmacy could think about were in these sort of advanced positions. And there were only about 27 of them that we knew about at the time. And we got a good sample, as you can see, because we were able to interview 7. I think the gender is reasonably reflective of the profession. Maybe we needed a few more men to join up, but they weren't in these positions. They were elsewhere. They were reasonably reflective of the ethnicity of our pharmacists in New Zealand. Our Māori are very underrepresented in health professions overall, probably similar to the Indigenous people in Canada and other nations in the world. But what we found very interesting is these workplace settings not only included primary care, but we ensured that we had community hospital, and we had a number of people who worked days of the week in different settings. And that provided us with a real richness in their experiences. These people were highly experienced. If we look at the median experience, almost 30 years experience. All of them were highly qualified. So you can see that we have people who've been taught to think as prescribers. They've done a lot of hard yards to really understand the knowledge and skills that are required for advanced pharmacy practice. And it's very interesting to see the different areas they studied. So we did have people who were interested in education, as well as business, people working in medicines information, mental health, palliative care, public health. So these people have very diverse interests and experiences. And we went back to the data to look at their stories. Now, we decided to look at activity theory. And I don't know how many of you are familiar with a real cultural historical activity approach. I'm not going to dwell on the complexity of this diagram, but it's just here for those of you who might be familiar. The way I want to pitch this simply as possible is pharmacy practice is an important activity. And we can look at different facets of it to illuminate that social situatedness of the project of providing care for people around medicines and drug therapy. So as we were looking at this analysis, it allowed me to reframe our theoretical lens. Instead of trying to balance non-maleficence and beneficence, what if we think that as pharmacists are engaging in their practice, that this is actually held in tension in our pharmacists? And so with some colleagues, we did some brainstorming. What might this play out in practice? And here is a brainstorm. So please, I'm not trying to overwhelm you while overwhelming you and saying, we were trying to look at the data that we were reading and then talk about what were the pressure points for our participants. Many of you who've done qualitative data analysis know that you can use software to do it, but sometimes throwing ideas on a whiteboard allows you to get rid of all of the detail to see this. And what we realized at the heart of this, if I go back a little bit, is the idea of this germ cell. The root of activity of a pharmacist is about this beneficence. We want to provide safe medicines for the people we care for. And this non-maleficence is we want the intended treatment to happen. Or if we think of the idea of intended consequences. However, when you are acting with beneficence, there is always the risk of unintended consequences. And we were really interested in seeing how do these pharmacists negotiate that? And how would we teach that? Where are we doing that in our curriculum? How are we exposing and helping students to make sense of this? So when we looked at the data, our findings, we saw that these advanced practice pharmacists were acting as patient advocates. If you look over here on the left of the screen, they were business people too. They were definitely trying to make sure the person receives the treatment, but they are involved in the business of pharmacy. And that's an area that is really unexplored in the literature, and I think might be an avenue I would love to pursue. Not only are they medicines providers, so they're still dispensing and checking and doing that, but there is the opportunity for them to be medication experts, but it's often done in the safety of working with a GP to make these recommendations or nurses. So it's still in this place of safety. We have the scope of practice in New Zealand that allows them to expand their practice, but they tend to keep it contained, which is very interesting. Another important area that we see them speaking about is their contribution to healthcare. What are the expectations they're holding for themselves and other health practitioners, and how that's impacting their ability to develop these medicine services here at the top of the screen. You'll notice I haven't added details there because I want to leave this open right now. And we look at the tensions that are generated by this decision-making responsibility. Who holds that responsibility? And are pharmacists willing to take on that responsibility? And we saw the stories of them often deferring to their other colleagues. So given this thinking, and I could probably spend an hour just talking about this diagram to you, but we're getting towards the end of our hour and I don't want to spend forever there, but we can go back here if you like. This has had a huge impact on Dan's thinking, and that he's revised the 4-step model into a very culturally contextualized model of care. So we're no longer thinking of this teaching this tacit process, but we're actually thinking about how does the practice provide care? And so the teaching and learning of this model has shifted profoundly in the last 5 years at the School of Pharmacy. And I'll let Dan speak about that in just a minute if you have any questions for him. This is a really exciting development because you can see not only are we incorporating the idea of practice, but we're trying to make sure that we're addressing the perspectives of our patients, not just pharmacists. And this has generated another research question because this is a moving feast. What are the characteristics of advanced practice in New Zealand? We have this 2018 data and we're constructing a study to re-interview these pharmacists and a number of pharmacists who've joined them over the past 5 years, because this landscape has changed profoundly, not just due to COVID, but because of many other pressures that are out there. So I kind of want to sort of end what I've been saying now with a question to you all to have a conversation for the remainder of our time together. How might our findings or this approach now inform this education practice problem or challenge in settings beyond New Zealand? What might be some of the key drivers in your context? So I'm going to stop here and stop sharing so that we can have a conversation for the last bit of this presentation. That's all. I gave you a lot of things to think about. I'm sorry.
Emily, go ahead.
I was just going to say, please do either raise your hand or ask your questions in chat, and Annalise and I will make sure that we recognize you and or read your question out. I just want to say, Megan, I mean, I find this whole thing very fascinating because you've given us a different perspective, a different way of looking at and understanding how pharmacists can make and contribute to therapeutic decision making. You know, and I think, you know, I'm always fascinated by stuff like that, but I think that, I guess my question to you is, what is your hope and dream at this point with regards to how this new information, this new insight impacts and changes the practice of pharmacy, both within places like the faculty in the way that we teach, but also in the way that we actually practice?
And I went to our clinic yesterday on campus and I took photographs of it, and I tried to actually get a picture of our practicing pharmacists with 2 fourth-year pharmacy students doing a teleconferencing call with patients yesterday. I didn't have a chance to upload them. What I think this does is help us reframe the teaching and learning. So we're not just classroom-based, stuffing the knowledge and skills. Yes, we do need our students to be knowledgeable, but when we talk to practitioners and students, their stories are not about, geez, I needed to learn more knowledge about this, because we have access to that. It's about navigating the expectations of ourselves and others. so that we can really reframe how the practice is perceived, not only by ourselves, but the public. So I think it really helps us get new tools to think about education and think about how we're placing students out in the community so we can help them make sense of these experiences and the contradictions in practice that they're going to see, because we might place them in this wonderful place where we see the future practice happening, but we also know we're going to place them into sweatshops. And how do we help them resolve that? I don't want to say too much more because I'll occupy all the remaining time.
Thanks for that. Katrina, I know you had your hand up, comment or question that you wanted to make.
2 slides back, I actually didn't understand something, and I'm wondering if you can help me. So it was the one where you were using Maori, I think, concepts, and it looked like you'd superimpose them on the pharmaceutical care process.
I'm going to let Dan answer that one because this
Correct.
is his baby.
Correct. That's basically the next step, was to take that original model, remember the circular model Megan showed, which had words in it that didn't make a lot of sense, clinical reasoning, this and that. It was all words that were negotiated space, and we thought they made sense at the time, and not so much now. It was basically just a pragmatic evolution. But yes, the care process and the one used in the US and also in Canada was a big part of that. Absolutely. It sort of superimposed. Yeah, sure. Yeah, absolutely. The piece that's slightly different though from the PPCP is the addition or the slightly more worked version of how do you actually get to a decision? How do you actually take all the information, the risk-benefit stuff that you might have from literature, from your own experience, whatever? How do you actually then synthesize that into something that you're going to move forward with in that negotiated space with the patient, as we were talking about earlier as well? There's a little bit more of that, and that's probably not explicit in that model. It is in the teaching material that accompanies that model. So, but you're quite right. It's based heavily on all the models that are out there. Actually, they're all quite similar.
Mm-hmm.
But the PPCP, of course, is well tried and true, and we're not going to abandon that in our teaching and our approach.
Yeah, and I think that helps me because now I understand that you are examining sort of this one particular micro step within that PC process.
Correct. Yeah. Essentially, when Megan and I visited a couple of universities in the US at one time a few years ago, and we presented our model, and they said, well, isn't this just PPCP with different words? And we said, well, yeah, that's exactly what it is. Do we need the different words? And that's, of course, got us thinking and saying, well, probably not. Well, the piece that we felt was missing was that it's the word I'm looking for. Sorry, it's early in the morning for me here. That tacit piece of how do we actually move through the decision-making process? How do we go from information to decision? That's the bit that we added in, I suppose, really. So you're quite right, Katrina, and I take your point very well. It's very pragmatic. It's designed entirely to be something we can throw into the teaching environment and use and experiment with, I suppose.
Thanks for that, Dan.
Okay, well, it is 4:54, which means it's also going to be 6 minutes to the hour where Dan and Megan are. So I would like to give everyone that little bit of time back to their day, whether you're headed home or just starting your day. But thank you both so much. What a rich conversation. What a rich discussion. I have to say, I've really enjoyed just the remarks throughout this conversation and discussion. And yeah, thank you to our small but involved audience online. It's always great to have people share perspectives. So thank you, Megan. Thank you, Dan. Very quickly, logistically, our CPE Speaker Series will be on pause over the summer, and we'll be regrouping in September or October with a new series of events coming your way. Thank you very much, everyone. Take care.
Thank you. Thanks for spending the morning with us, you two. We appreciate it. Thanks for everyone else for joining in too.